So I'll start. My name is Irfan Aga. I'm a nephrologist in Dallas. So can everybody, you want everybody to introduce themselves with this?
Yeah, maybe just like a
just everybody, if you could just say one line. So Avas, why don't you go ahead, please?
Okay, I'm Avas Masood. I'm in New Jersey. My specialty is nephrology and critical care. I'm program director here for Nephrology Critical Care Fellowship, and that's it.
Okay, I'm Alias Gadlenwala. I've actually done my adult nephrology boards and I did MedPed, so I have dual qualifications. I do pediatric nephrology in Karachi, SIUT, last 10, 15 years. So.
I am Colonel Zahid, and I am a nephrologist in CMH Lahore. I do critical care and nephrology.
I'm Omar Farouk. I'm a nephrologist at Penn State University in Hershey, Pennsylvania.
I'm Dr. Aurangzeb Afzal. I'm Associate Professor of Nephrology at Lahore General Hospital.
I'm Dr. Irfan Elahi. I am a nephrologist in Mayo Hospital, Lahore.
I'm Dr. Salan. I'm a nephrologist at Gulab Devi and Abi Latif Hospital in Lahore.
I'm Dr. Muzammil Rasmali.
So my name is Ahad. I am a consultant nephrologist at Berry International Hospital. Sorry, Muzammil, I'll introduce you.
Sir. My name is Dr. Muzammil Riaz Malik. I am assistant professor in nephrology in Sargodha.
I guess I can introduce myself now. Can you hear me?
Yes.
Yes.
My name is Shanila Latif. I'm a Dawite. I'm the only pathologist as of right now in this meeting. I practice transplant pathology, regular surgical pathology at San Antonio, Texas, and cytopathology. So I have like 2 fellowships, one in renal pathology and one in cytopathology.
Well, you're a huge asset for us.
Thank you.
Yeah, I'm Mujtaba Qadri in Islamabad. Assalamu alaikum, everyone.
Alaikum salam.
I am Dr. Numan Tari from Lahore. Assalamu alaikum.
Assalamu alaikum. Yes, I am Dr. Kasser from Gujranwala. Assalamu alaikum.
Well.
Irfan, you can start now, please.
All right. Well, let's get going. Welcome, everybody. Thank you for joining us this Sunday evening for you and Sunday afternoon for us. We're going to talk about FSGS today, but it is a huge topic. So what we're going to do is we're going to split it into 2 talks. So what we decided is to use the first Sunday of every month as the GN day. So next Sunday and next month, first Sunday, we will complete the FSGS thing. If you wouldn't mind, everybody, please mute your microphones because sometimes we get feedback and that disrupts the talk. This is going to be an interactive session, so please raise your hand or unmute yourself or send a message in chat. Umar, my friend, if you could monitor the chat because I find it hard to talk and also to keep an eye on the chat. If there's a question that needs to be addressed straight away, please interrupt me and we can discuss that. If there's a question that can wait, we can then wait till the time we hit one of the breaks. And
can I interrupt you 1 second, please?
Hello?
Can I interrupt you 1 second?
Yeah, please.
Yes, so this is a big topic on FSGS. So I left the next Sunday open because I want, if any question comes out and obviously you were not able to finish, and if you are available, next Sunday we can continue, and after that, every first Sunday of the month we can continue as GN.
I'm okay with that. I'm okay with that. We can do it that way.
Yeah.
So, we'll deal with the basics and initial therapy today, and the next session will almost entirely be dedicated to difficult cases and transplantation. And before I start, let me take a moment of personal privilege. Today is September 6th, so I would want to recognize Colonel Zahid, and on behalf of everybody here, thank him for his service. So, before we start, we need to get this thing clear. FSGS is a pathologic lesion. It is not a diagnosis. Sometimes people read the bottom line of the pathology report, and every FSGS is dealt in the same way. It is a potpourri of different diseases. The lesion itself is the tombstone of a podocytopathy. So the way this works is any inciting factor that is injurious to the podocytes can eventually lead to an FSGS type pathology. So the inciting event is podocyte injury, and usually the diseases that cause FSGS lead to diffuse podocyte injury. So it behooves us to figure out why is the lesion focal and segmental if the podocytes are involved globally. And once we go through the next few slides, that will become clear. And I'm going to speak for just about 10-15 minutes to set the stage. And again, if I might request everybody, please mute your microphones so that there's no feedback. So I'm going to speak for about 10 or 15 minutes today and just make a brief number of points. And after that, we'll go into case discussions. So this is a normal glomerulus, or part of a normal glomerulus. And on the left side, we have a cartoon of it to kind of explain what is going to happen. So let me walk you through what this shows. This is obviously a capillary loop, glomerular endothelial cell. You've got the basement membrane, podocytes, the urinary space, and then the parietal epithelial cells and the Bowman's capsule basement membrane. So let's take a look at the pathology panel here. This is obviously Mason's trichrome. You've got capillary loops that are nice and open over here. You see the endothelial nuclei. You see the podocytes on top of them. So this is the guy here. You can see it over here. You have the nice and open urinary space. You've got the Bowman's capsule basement membrane and a parietal epithelial cell. So this is a normal glomerulus, and this is depicted on the left side in the cartoon form. So what happens with FSGS? Like I said, the cardinal problem in FSGS is podocyte injury. Whatever is going to lead to the disease is going to lead to diffuse podocyte injury. When the podocytes get injured, there is an intense refractory reaction. The actin cytoskeleton retracts the cell upwards, which actually leads to effacement of the podocytes. So instead of having these nice, discrete foot processes, it turns into these knobby stubs. They're all kind of fused, and that's because the cell has kind of retracted back. When that happens, there are areas of the glomerular basement membrane that are denuded of podocytes. So this is why some areas might be, some areas might not be, but the areas that seem to be the worst hit, the glomerular basement membrane is denuded of foot process or epithelial cell, podocyte coverage. That leads to ballooning of the glomerular basement membrane towards the parietal cells, and eventually there is an adhesion that forms between the basement membrane of the glomerulus and the parietal epithelial cells. Initially, this is cellular. So what you're seeing here is a bunch of cells, and the glomerular tuft here is in touch with the parietal cell layer. So this is the Bowman's capsule basement membrane. You've got the parietal epithelial cells. They are now in touch with the capillary tufts. Now, you see a bunch of nuclei over there, and there's kind of a considerable amount of discussion on what the origin of these cells is. Initially, over the years, we thought this is podocyte hyperplasia. But we also know that podocytes are terminally differentiated cells and they can't divide. So there is some thought now that actually these are not podocytes at all. These are actually dedifferentiated parietal epithelial cells, which actually walk through this cell bridge over onto the top of the capillary loops and start replicating. But in any case, what is happening over here is that there's a cellular connection between the glomerular capillary tufts and the parietal epithelial cells. So this is known as a tuft adhesion. And so once this cell bridge forms, there's a couple of things that start happening. There is a proliferation of the parietal epithelial cells, which have now started migrating down. And also the glomerular filtrate is leaking over this adhesion in the periglomerular space. That eventually leads to interstitial fibrosis. You can kind of see the deposition of fibrillar collagen and some trapping of plasma proteins here, which leads to hyalinosis, which we see quite frequently around these lesions. And eventually, these reactions start obliterating capillary lumens. As I mentioned, that when these gaps form because of this tuft formation between parietal epithelial cells, the cell filter, the glomerular ultrafiltrate starts leaking around in this periglomerular space. This is called misdirected filtration, and eventually, not only do these areas scar up, the misdirected filtration walks on both sides of the glomerulus and eventually leads to tubular atrophy as well. So over here, what you're seeing is a fully formed scar. So this is segmental sclerosis with collapse of the capillary lumen. Now, this is not collapsing nephropathy. It's just that the capillaries here have been obliterated. We'll look at the examples of collapsing nephropathy, which is a very different animal, actually. So this is how you develop the lesion of focal segmental glomerulosclerosis. And like I said, and I cannot emphasize it enough, what starts it is damage to the podocytes. Now, it doesn't matter what the damage is from. Once this happens, you get the ball rolling to develop an FSGS type lesion. Now, FSGS lesion is not a disease. So what causes the FSGS lesion is the disease that we need to treat. So at this point, I'm going to hand it over to Dr. Latif, who is going to walk us through the common histopathological patterns of FSGS that we see. So Shanila, I'm going to put on your first slide.
Okay, so I'm going to start with Columbia classification. This is FSGS NOS type. Simply means it can affect any part of the glomerulus. It could be the top, the base, the right, the left. So whenever we don't see a typical lesion, we just lump them together as NOS, and this is the most common type that we always see. It simply means it's pretty much a little bit advanced stage, because all the different variants, which I'm going to discuss next, they eventually become NOS type. So we lump, it's basically a waste basket diagnosis. Once we cannot make a definite what type of FSGS is that, once the disease is not early enough at the time of biopsy, then it becomes NOS, and you can see there are dark pink hyaline material on my left hand side and the right hand side, and a little bit at the hilum area, and then the black slide is a silver stain, and the silver stain highlights all those sclerotic, fibrotic areas. Yeah, exactly. And right there in the middle, the very pink material is hyaline material. So this is like a most common one. So we start with this one. Next slide, Irfan bhai. Okay, so this is an example of a tip lesion. Why we call this tip lesion? Because it affects, or it starts at the proximal tubular pole of the glomerulus. So what happened here is, like, the proximal tubule and the glomerulus, they started having this fibrotic reaction, and histologically, it looks like that the glomerulus is prolapsing or opening in a proximal tubule. I guess this has the best prognosis. That's why it's important for our nephrologists to know if this is a tip variant or not. They act very well if we can diagnose early enough. Like for FSGS, I guess on biopsy, the most important is when the biopsy is done and how early is the lesion. Once it's advanced disease, it's hard for us also to classify, and it's hard for the nephrologist also to treat. So the middle picture, you can see one of the tubule right there at the tip. Yeah, right there. It's opening in the proximal tubule, and this is another example right here. So it's opening in a proximal tubule. And I guess the right-hand picture is a PAS stain. That's why you can see more pink basement membranes, and the tubular basement membranes are also very pink. And the leftmost picture is right there. It's showing you how the glomerulus is prolapsing in a proximal tubule. Next one, please. Okay, this is an example of perihilar lesion. The arrow is showing the hyaline deposit there. Is basically proteinaceous material. This is an early sign which we have to pay attention, because if we miss this hyaline material, we can miss this perihilar lesion. So even if I see 1 or 2 hyaline nodules, I always suggest that this could be very early perihilar, like a hilar type of FSGS. To make this diagnosis, according to Columbia classification, you have to have 50% of the glomeruli involved by perihilar lesions before you can call it perihilar FSGS. For all other different types like tip lesion, collapsing, and cellular variant, if I only see one glomerulus in that variant, I call it. But for the perihilar lesion, they call it more than 50%. If you don't have more than 50% perihilar lesions, then you just call it NOS, FSGS NOS type. Okay, the next one. This is a good example of cellular variant, and I want to basically go in a little bit more detail with cellular variant, because cellular variant can be sometimes very confusing. The way it looks, it gives you more cellular, like a kind of a neutrophil infiltrate there, increased cellularity there, pseudocrescent there. Some people can confuse this with crescentic GN, because it's showing you some neutrophils, some karyohexes, and some epithelial cell proliferation. Looks like a pseudo, but it's basically a pseudocrescent. It's not a true crescent, because it never causes the necrosis of the Bowman's capsule, and it also never involve the too much parietal epithelial cells. Usually the podocytes that are proliferating and giving you a pseudo effect of crescent. This is like, you can see part of the glomerulus is hypercellular as compared to the upper half, which is normal. The lower half is hypercellular. And on the trichrome stain, you also can see the hypercellular areas. it's right there, and you can see some foam cells also, the vacuolated cells. So that's another indication. When you start seeing foam cells, think about FSGS cellular variant, because usually crescentic GN won't give you this many foam cells. And plus, majority of the crescentic GN gives you immune complex mediated disease, right? So you see immune complex deposits on EM, except the posse immune, the ANCA disease won't give you any, but that's the only differential. So we try to do serologies like ANCA serologies, make sure the patient has no C-ANCA or P-ANCA positivity before I call cellular variant, because that's the only differential you can miss if you don't do serologies in these patients and you call it cellular variant of FSGS.
Go ahead, I'm sorry.
And sometimes advanced ANCA disease, all they give you is FSGS. So that's another problem in older patients. If I have no clinical history of negative ANCA disease or negative serologies for PNC ANCA, I call it FSGS, and then the clinicians call me, oh, by the way, this patient has serologies positive for ANCA. Okay, so it could be an advanced ANCA disease. So be careful to call cellular variant of FSGS, because you have to rule out all the immune complex mediated diseases and ANCA disease first before you can call cellular variant. Okay, next.
Before we go on to the next slide, let me make a quick point, and that is there's a little bit of ambivalence in the in the nomenclature. So the cellular variant of the Columbia classification, that's the Agnes Fogo and Vivek Degadi project of the past 15-20 years, is a little different from sometimes what is referred to as cellular variant of FSGS in the literature of the 80s and the 90s. That cellular variant was sometimes used for what we today call collapsing collapsing FSGS as well. So when you're reading an older paper, just be sure not to confuse the cellular variants, because your prognosis, etc., would be a little different, and they're talking about different diseases at that point. But in today's time, if you're going by the Columbia classification, this is what the cellular variant is.
Next is collapsing FSGS. So collapsing.
Guys, can we please mute our mics, because there's crosstalk in there and that's disruptive for the talk. Thank you. All right, that's it.
Okay, so collapsing variant, the left-hand side, the picture is very, can explain very well. You can see the black color is the basement membranes of the glomerulus. Like those are the capillary loops, and they all are in the center, surrounded by these pink cells, which is like a proliferation of podocytes. So all these are increased number of podocytes that are pushing the capillary loops and collapsing the capillary loops. You can see the similar picture in my biopsy. Here you can see the dark black color. It's a silver stain. That's why you can see you can see the capillary loops in the middle, and the pink cells are the hyperplasia of the podocytes. So basically in this variant, and the only thing a little bit different in this variant, it's most of the time, majority of the time, it involves the entire glomerulus. It sometimes can be segmental, but it's involved, most of the time it's involving the entire glomerulus, and because of the hyperplasia, the capillary loops are all collapsed. There is another example here also. See, it sometimes can mimic a pseudo crescent also, because all these podocytes are surrounding the capillary loops and causing the collapse of these capillary loops. So the majority of the urinary space is filled by these podocytes. They are podocyte, and I guess this has the worst prognosis. That's why we have to pay attention to this variant. And to diagnose this, all I need is one good glomerulus with collapsing features. I can make the diagnosis. It doesn't matter what the rest of the kidney look like. If I can see this one good glomerulus with so much podocyte hyperplasia, that's what I'm gonna call it. So yeah, these lesions, only you need to see one or more good glomeruli, except the perihilar variant, which is you need to have 50%. Next one, Irfan bhai. Okay, so this is a EM pictures of all these different variants. I mean, it's hard to go in too much detail with the EM, but I'll just show you the basic, the most common features. For those foam cells, the ones on my right, the one on my right hand side, these are the foam cells. Basically, they are sometimes swollen endothelial cells, monocytes. They contain lipid vacuoles. That's why they look like foam cells. And then on top of them, the foot processes are all effaced. They are like all together in one straight line. Here you can see the basement membranes are wrinkled, and this whole thing is kind of a sclerosed, the middle segment picture. And this first one, you can see the uplifting of the foot processes. So the basement membrane, there's a space in between the basement membrane and the foot processes, and the middle space is filled by new collagen material. So once they start forming this new collagen material, sometimes on trichrome stain, if you do it in these glomeruli, you can see a little bit lighter collagen, and it's called uplifting of the foot processes. The way sometimes in minimal change disease, you also see the effacement of foot processes, right? But if you see this feature of uplifting of foot processes, you should think about early FSGS, because this is that, like on EM, you can see that feature, and podocyte hyperplasia also sometimes you can see on EM. So yeah, the EM is, some people think that EM is diagnostic for FSGS. Believe me, on EM, if I don't have any foam cells, if I don't have any uplifting, I cannot make a difference of FSGS and minimal change if I just have the effacement of foot processes. So the way we deal with those cases, that we just tell the clinicians, looks like effacement of foot processes, could be minimal change. If it won't respond to steroids, then think about FSGS. So there will be always a comment in my report that the histologic features consistent with minimal change, but if patient won't respond to steroids, then consider the diagnosis of FSGS. I think this might be the last one or the next one. Irfan bhai, there's one more. That's it. Thank you.
Thank you very much, Shanila. So, you know, as clinicians, we always kind of see what the morphologic classification is, and there's a bunch of renal histopathologists that are really pushing this, but at times I don't find it entirely useful. But there are certain associations, and I think the most important thing is to identify that this thing, collapsing GN, is a totally different animal compared to everybody else. So if you find, like Shanila said, even one glomerulus with collapsing lesions, that trumps everything else. It's like, you know, poker, where if you have collapsing GN, that wins. That's the diagnosis. You've got that. The association of collapsing GN in our United States populations is very strong with APOL gene mutations. That is not a big problem in Pakistan, so we will kind of not spend too much time on APOL gene issues. The TIP variant is the version of FSGS that behaves the most like minimal change. If you have TIP, those have the best softer compared to everybody else, to steroids. But the interesting thing is, like Shanila said, it's a time issue. So if you have just the tip lesion, that's what they retain. But they have if they have the tip lesion and also develop an NOS type lesion, then their prognosis changes and they start behaving more like an NOS lesion. So just think of this in the context of kidney transplantation. That's where we catch this disease really early. And the first thing we see when we biopsy them 2 weeks after transplant, they develop massive proteinuria, there's recurrence of FSGS. You biopsy them, you're not going to see any sclerotic lesion. All you're going to see is diffuse foot process effacement, because that's what's actually leading to the proteinuria. But if you let that sit for a little bit, or if it doesn't respond to treatment, then you're likely to see a tip variant show up, and down the line, you're going to see an NOS type picture develop. So the longer you wait, the worse it becomes for the patient. And this is why in post-transplant FSGS, plasmapheresis works. It doesn't work in our non-transplant patients because we are way behind on the game. The cellular variant, Dr. Latif talked about, it's kind of almost sounds like a transition point where it can actually move into a full collapsing version later on. The Pennyhiler variant is interesting because it is seen most commonly in the adaptive FSGS scenario. So this is not the type of lesion that is probably going to respond well to immunosuppression, but we'll talk about that a little bit more. And then the FSGS NOS is the classic FSGS lesion. A couple of other points. FSGS, the immunofluorescence is usually dark, so pretty much everything is going to be negative. There may be subtle IgA there. So sometimes people get fooled by that. They have an FSGS type picture. There's a little bit of IgA there, and you say, okay, maybe this is IgA nephropathy. Similarly, you can have a little bit of IgM, and we have an example of that in one of the cases where there's a little bit of IgM that can get trapped in the scar, and that really doesn't make it IgM nephropathy, and there's other issues that we need to look at. And then we have to keep in mind that you can have SLE, you can have membranous, you can have IgA nephropathy, and develop secondary FSGS, because all of those diseases affect the podocytes as well, and you can develop secondary sclerosis. So that FSGS is just secondary to the parent disease. It is not that you've got two disorders going on over there. So let's kind of see how FSGS works. Like I said, the basic issue that happens in FSGS is podocyte injury. Whatever causes the injury, doesn't matter. After that, once you've got that ball rolling, it kind of behaves about the same. So you may have genetic predisposition, you can have slit diaphragm protein problems, which is something that Dr. Aliasgar probably sees more than we do, because most of these are autosomal recessive and congenital nephrotic syndrome type issues, nephrin, podocyte, etc. These could be actin cytoskeleton issues, alpha-actinin 4, or other issues that lead to cytoskeletal problems, CD2AP or TRPC6. Or these could be integrin problems. So these are the proteins that actually anchor the foot process to the basement membrane. And if there's a problem with that, there's lifting up of the foot processes from the basement membrane, leading to podocyte injury. We all talk about these various circulating factors. SUPAR is one of them. CFC is another one of them. Every 2-3 years, somebody publishes an exciting study that, yeah, we got it. And then when we do validation studies, it turns out we don't got it. So at this point, none of these tests are ready for prime time, but there's obviously a lot of research going on. Mechanical stretch can lead to podocyte injury. So if you've got hypertension, that's what leads to secondary FSGS there. Toxins, most commonly are drugs. Bisphosphonates, lithium, interferon. Interferon actually works slightly differently. It actually causes upregulation of APOL1 transcription. So if you've got an APOL gene mutation, and if you put that person on interferon, that's how it leads to an FSGS type lesion. Several viral infections, HIV is the commonest, and again, HIV leads to collapsing FSGS in patients who are APOL gene homozygous. So it's kind of This is exciting research that is coming together now. In the immunocompromised patient, you can see CMV, EBV, and sometimes parvo B19 that can lead to an FSGS type lesion and many other issues. So whatever is causing this will lead to injury and detachment of podocytes, and sometimes would lead to cell death. If there's enough persistent injury, the podocytes will die and they will be depleted. Each glomerulus has about 800 podocytes. So eventually, if you lose enough of them, you have glomerular capillary denudation. There are certain instances, there is some research to suggest that some numbers of podocytes may reconstitute. We are not sure where this is coming from, either the parietal epithelial cell or some cells of renal lineage that can repair the glomerulus. But in most cases, if you have persistently low number of podocytes, you will go through all the things that we talked about and develop progressive FSGS. So as clinicians, what do we have to do? What we have to do today is to be very cognizant that FSGS is many things to many patients and many doctors and many pathologists. So we have to make sure that everything is squared away and that we are all speaking the same language. So when we say FSGS, the thing that we really want to talk about is the immune permeability factor related FSGS. Now, we don't know what that factor is, maybe SUPAR, maybe CFC, maybe something else, but this is the FSGS that presents with thunderclap surprise. Nephrotic syndrome, patient was fine 2 or 3 weeks ago, now their legs are swollen. They've got massive amount of protein in the urine, the albumin is low, cholesterol is high. That's the one we look at because that's the only one of all these which is going to respond to immunosuppression. So if we don't take care in separating all of these, then we are going to be throwing a lot of toxic medicine on diseases that are not going to respond. Adaptive FSGS in adult nephrology is the other biggest bag. So this is what we used to call secondary FSGS. If you've got renal agenesis, if you've had severe ATN in the past, anything that has led to a decreased renal mass, that leads to hyperfiltration, eventually injury of the podocytes, and progressive FSGS. Similarly, if you've got advanced hypertensive disease, which stretches the glomerulus, causes denudation of the glomerular basement membrane from the epithelial sides, and leads to the cell bridge formation, that's what leads to a secondary FSGS lesion in hypertension. Infections and drugs we talked about, genetic disorders we talked about, again, slit diaphragm proteins, the cytoskeleton proteins, and the anchor proteins. And then there are some FSGSs which are NOS. We don't know, not NOS, I'm so sorry, I shouldn't have used that word, which we don't know about. And you know, so we sometimes are unable to put a particular patient in a particular bucket. So as clinicians, as adult nephrologists, you know, we have to sometimes make this call. Is this a permeability factor related FSGS, also known as FSGS that may respond to immunosuppression, or is this adaptive FSGS, also known as FSGS that is not going to respond to immunosuppression? And so usually this presents with nephrotic syndrome. This presents with proteinuria. It could be nephrotic or subnephrotic, but usually we do not see nephrotic syndrome. So all the trappings of nephrotic syndrome, hypoalbuminemia, hyperlipidemia, severe edema, at least early on, we don't see with them. Light microscopy is FSGS for both. There's a question that adaptive may have some perihilar propensity that, like we talked about. Glomerulomegaly is uncommon in permeability factor related FSGS. It is common in adaptive FSGS. And Shanila, correct me if I'm wrong, glomerulomegaly is defined as the average size of glomerulus, which is 1.5 times the size of what we expect. And in these patients, you see other signs of scarring. You see a lot of vascular change, etc. And then again, in Pakistan, this is a little bit of a handicap. You can't get electron microscopy, but if you get electron microscopy in these, you see diffuse foot process effacement, whereas in adaptive FSGS, you see segmental foot process effacement. So this is the general approach, and this is not something that we follow even in the United States, but just to kind of put the thing in context here. If your patient is presenting with nephrotic syndrome and has significant food process effacement, that is more than 80%, you have a diagnosis, you're probably dealing with immune factor related FSGS, and you can start immunosuppression on them and kind of walk through, and we'll talk about some of these things as we progress in our formulation. If the food process effacement is less than 80%, a lot of people are doing genetic testing, and we'll talk about this a little bit with patients to get genetic testing on. In the US, it is becoming easier and cheaper. Just a few years ago, in order to get genetic testing, even through targeted Sanger sequencing, you would have to spend $2,500 to $3,000. Now you can get a fairly comprehensive genetic panel shotgun through next generation sequencing for about $300. So that's not bad at all. Now, if your patient has presented with subnephrotic proteinuria or nephrotic range proteinuria without nephrotic syndrome, again, look at the food process effacement. If they've got more than 80%, then what does that mean? That probably means they've got a genetic problem. And again, the genetic problems that we see in adult population are going to be different from what Dr. Aliasgar sees in his population. We would see this very slowly progressive proteinuria. They'll say, oh yeah, 10 years ago, I went to my doctor and they said I had protein in the urine, but that wasn't too bad. And it's a slow burn disease. It's an autosomal dominant inheritance pattern if you can tease it out. And most of these are actin cytoskeletal proteins. So CD2AP, alpha-actinin 4, trypsin-6, so on and so forth, that are involved. In the pediatric population, you see the slit diaphragm proteins, so your nephrin and potosin, NPH1 and NPH2, NPHS1 and 2, which are autosomal recessive and present with florid congenital nephrotic syndrome called the Finnish type of disease. If your food process effacement is less than 80%, then you look at some of this other stuff. But understand that the only type of nephrotic syndrome that is actually going to be worthy of immunosuppression is this constellation. Acute nephrotic syndrome, massive food process effacement, and then you can give them a trial of immunosuppression. And we've gone through the different types of FSGS and everything. The outcome of FSGS depends on only one thing. Are they going to be steroid sensitive or not? Steroid sensitive nephrotic syndrome of the immune factor type fares way better than anything else. When I say anything else, I mean when it's a circulating factor driven FSGS. So are there any questions before we go on to cases?
Sir, I had a question regarding the histopathology.
Yeah.
Yeah. So first of all, I would like to make a comment that there was a confusion with me, and you precisely pointed it out regarding the cellular and the collapsing variant difference. That was a confusion that I found in literature, and I was thinking that it was only me, and I wasn't able to discuss that with somebody else. So good to hear that the old literature still it lingers on in some of the books and literatures. Regarding Dr. Latif, I was just curious about one thing. She was telling that cellular variant is frequently reported, and later on sometimes we as clinicians tell that ANCA is positive and then the decision is changed. I was thinking the cellular variant is a rare entity and it's not usually reported as frequently. So if it's reported to some frequency, that would be interesting. And secondarily, it is endocapillary proliferation that we cause a cellular variant. That's one thing I want to be sure about. And very last thing, the confusion is sometimes the vasculitis has come and it has gone away. Now there is a scar after that. And the scar after that contains type 1 and 3 collagen, and it's relatively lighter in past staining. On the other hand, the focal segmental glomerulosclerosis, it contains the basement membrane and the PAS is relatively brighter. Can we make some kind of graduation or the degree of positivity of PAS, and on that basis we can comment it's a old healed scar as a sequence of some old vasculitis, or it's a glomerulosclerosis of some other sort? And if the question is really long, I know, but if I may add one more thing. Regarding electron microscopy, we don't have that. So after listening to these comments that electron microscopy isn't that helpful, it's relatively a little more surprising for me, because I used to think it's extremely helpful. The degree of podocytopathy, if it's less than 25% or it's greater than 80%, it helps you to diagnose. So what is the most important thing that you look in EM? Is it the percentage of podocytopathy or uplifting of this basement membrane and the foam cells?
All right. Thank you very much. Thank you very much. So let me answer the third part of this, and then I'll turn over the rest to Shanila. So no, I think I perhaps was not clear. I think it's exceedingly important to look at the degree of podocytopathy. I never said that electron microscopy is not important. All I was trying to say was that you don't have it, so you have to compensate for it in other ways. We look at it very, very carefully. And use it extensively in creating a composite to make this distinction. So Shanila, the two questions that I think, if I may condense them, the first thing is about the cellular variant of how to grade that a little bit better. And the second thing is, how do you differentiate an old healed scar from a vasculitis from a focal segmental lesion, which it probably is. So I'll let you take that.
Irfan bhai, okay, so let me start from the EM first. The problem with FSGS, you all know that sometimes this disease starts from corticomedullary junction, right? And if the biopsy is not deep enough, and if the biopsy doesn't have 25 glomeruli on your specimen, you can miss it. It's a focal disease, and segmental means focal means few glomeruli involved, and segmental means part of the glomerulus is involved. So you can miss it. That's why EM is important, because EM, sometimes those normal looking glomeruli, all they show is effacement of the foot processes, and sometimes little bit uplifting. Those are the most important features. I mean, I was not trying to tell you that EM is not important. EM is very important, but if you don't see uplifting, if you don't see any histologic features of FSGS, just the effacement of foot processes, then you cannot differentiate between minimal change and FSGS. And we have seen recently, or like in my whole career, that lots of time the report says minimal change disease, but the patient won't respond to steroids, and then they rebiopsy, and then it is FSGS. So that's why on HNE, EM, and immuno, all three are very important. And the second question is regarding cellular variant. So I'm not saying the cellular variant is common. I'm saying the people can confuse the cellular variant with anchor disease, because histologically they both can look almost similar. The only way you can eliminate a focal proliferative GN or crescentic GN with the cellular variant is make sure there is no immune complex deposits on EM, and make sure the immuno is negative, because in FSGS, we should not have any immune complex deposits. Regarding the PAS stain or trichrome stain and differentiating new scar and old scar is very subjective. Like one pathologist will say this is old scar, one will say this is new scar. It's hard to make the differential diagnosis on those stains, but EM and immuno can tell you. If there's no deposits on immuno, if there's no deposits on EM, I'm not gonna call it lupus proliferative GN, or I'm not gonna call it post-infectious GN. You know, all these proliferative GNs which give you crescentic appearance can mimic cellular variant. That's why it's very important to exclude all those things before you can call proliferative GN. So basically you have to exclude lots of things before you can make diagnosis of cellular variant of FSGS. That's what the answer is. And I guess I try to explain the reason, but I don't go with the staining dark or light or those things, because those are very subjective.
All right, thank you very much. So in the interest of time, we'll move on to the cases now. So the first case is a 41-year-old Indian male. He was diagnosed with hypertension in 2005. And these are all real cases. And actually today's, all of them are mine. So 41-year-old Indian male diagnosed with hypertension in 2005. Your analysis at that time was 1+ protein. His blood pressure was difficult to control. He started developing chronic kidney disease. His creatinine in 2013 was 1.6. He eventually presented to a nephrologist, not me. He went to another nephrologist in early 2017. His creatinine was 3.9 with 4 grams of protein in the urine, and a kidney biopsy was performed. And his biopsy showed on light, he had 3 out of 8 glomeruli with focally sclerotic lesions. 4 of the 8 glomeruli were globally sclerotic lesions, and 1 glom looked normal. He had marked IFTA with severe arterial and arteriolar hyalinosis. Immunofluorescence was negative, and he had significant foot process effacement, and they reported 50 to 60%. So what do you guys want to do with him? Anyone want to treat him with steroids or cyclosporin or any other immunosuppression at this point? How would you like to treat this guy? He's got marked decrease in his GFR. His creatinine is about 3.9. He's got nephrotic range proteinuria, but does not have nephrotic syndrome. Any ideas?
I'm just gonna control the protein. I would say, okay, just control the proteinuria, because looks like it's an advanced disease, Irfan. By 90% of the glomeruli are involved either globally or segmentally sclerosed. There's nothing much left there to treat. But I'm not a clinician, so let them talk.
Well, I think I'm sorry, go ahead. Somebody was trying to say something.
No, Wes, can I comment on that?
So, I'm sorry. Say that again,
Wes, yes. So I'm looking at this, 4 out of 8 glomerulus are, globally sclerotic with history of hypertension. We see sometime in the initial stages, we see some biopsy report that's not like a segmental sclerosis, it's like a global sclerosis with history of hypertension. This is a younger patient, but if you see the older patient, so that is a different disease, right? This is not a focal segmental, they are focal global sclerosis that can come with the hypertension and with the age.
Right.
And this particular patient is a younger patient. She probably had the same disease, but again, pretty advanced, like a creatinine already 3, and I think at this stage, probably in the long history, if his immunosuppressant will be not that beneficial compared to the side effects we can get from that.
Yeah, I totally agree with you. And just to say, Shanila, you're betting better than the clinician who saw this patient, because they actually gave him a full course of steroids, and he gained 20, 30 pounds with that. Then he was placed on a calcineurin inhibitor. He didn't have any response, as he wouldn't have, because even if we had caught this early, this is very clearly describing a secondary, an adaptive FSGS secondary to severe hypertensive kidney disease. So anyway, he eventually was taken off all immunosuppression. He came to our GN center for a second opinion. So we stopped all of his immunosuppression. He was able to tolerate a little bit of an ACE inhibitor, but he was eventually transplanted. So what's his risk of recurrence? Should I be worried about recurrence in this patient? Anybody would have any trouble with that?
कुछ नहीं यार समझ कुछ नहीं आ रहे इसकी रिकॉर्डिंग ही सुननी पड़नी है बाद में YouTube पे अपलोड करें ये केस ये अच्छा बड़ा अच्छा रन कर रहा है अच्छा ऐसे केस में कहते हैं प्लाज्मा फीचर का रोल उसमें है किसमें ज्यादा गरीब हाँ तो उसमें है ना हाँ तो उसमें है ना नेटिव में नहीं है उसमें है क्योंकि उसमें सर्कुलेटिंग फैक्टर ज्यादा इंप्लिकेटेड है ये थोड़ा सा अजीब सा मैंने ये क्वेश्चन पूछा था कि व्हाई नॉट अ सर्कुलेटिंग फैक्टर इज मोर इंप्लिकेटेड इन प्राइमरी FSGS
Okay. May I respond to the question?
Yes, please.
Okay, so the question is that are we worried about recurrence in this patient?
Right.
Well, from the statistics, we know that these kind of FSGS, they usually don't recur that much. It's different in different centers and studies. I think it's 15 to 30% when they recur. But it all depends what kind of transplant did we do. If it was a deceased organ or a live-related donor. Because if it's a live-related donor, we are more worried that you know, if they will lose this kidney to this de novo disease or its recurrence, then the risk is, you know, the cost of that is too high. So in those cases, we keep them on very strict surveillance, and I don't think we would give them anything like rituximab or plasmapheresis preemptively about the recurrence, but I would just be a little more aggressive, and if he would start developing some kind of proteinuria.
Dr. Mughal? Dr. Mughal there?
Bedridden.
161
और इससे पहले कितना था
All right. Okay, I think we
Dr. Aliaskar, can you please tell us your opinion again? I think we just could not hear it properly.
I couldn't hear anything, so thank you.
Because I think that's a very good discussion point. We would like to have some discussion on that topic.
Sure.
Too, maybe.
Sure. My only point was that knowing that the chances of recurrence are 15 to 30% in such cases, where if he has received a live related kidney, then I would be more aggressive, and I'll monitor him more closely for chances of recurrence. And if I'll see proteinuria, I'll do early biopsy and give the treatment for recurrence early and more aggressively if he has received a live kidney. But for a deceased organ, we can tolerate a little bit more, and you know, we have to save him from the consequences of aggressive immune suppression. So in those cases, although monitoring is the same, but the aggressive nature of immune suppression, if they develop some kind of recurrence, is a little less.
I think that's a very worthy point of view. Let me just kind of, and this is, I think, where this discussion is very, very useful. So we have to think about what causes recurrence in an allograft, and what causes recurrence in an allograft is a circulating factor that immediately goes into the transplanted kidney, homes onto the podocytes, causes them to get injured, and leads to massive protein leak. I've had people who went home with 2 grams per gram of protein and 2 days later came back with 30 grams per gram of protein. It is thunderclap, it is massive. That's the only recurrence we actually worry about. That's immune recurrence. So an important you know, advantage of actually classifying the patient correctly is that it gives you a prognostication on which one is likely to recur. So in this particular situation, this patient, this 41-year-old Indian gentleman, does not have immune permeability factor related FSGS at all. He has adaptive FSGS because of chronic hypertension. And this does not have a circulating factor related with it. This is because of the stretch damage to the podocytes. And once you put a new kidney in, his chances of recurrence are really, really low. So when we look at FSGS recurrence data, we look at the entire gambit. And so what that does is it inflates the risk of recurrence for all of these guys, but it actually dilutes the risk of recurrence for this person. These guys recur quite frequently. So if you've got an immune permeability factor related FSGS, which is not conferred, their chance higher than actually like 50%. A FSGS does not recur because it is not related to a circulating factor. Similarly, infection-related FSGS does not recur because the infection has come and gone. There's no circulating factor. It's not going to be a problem. Drug-related FSGS does not recur unless, you know, they're continuing to use that drug for whatever reason. Genetic FSGS also does not recur because now the new kidney, unless it comes from a living related donor, that's the point that Dr. Lehman was making, that if it comes from a related donor, there may be a partial expression of some of the genes, especially if it's an autosomal recessive problem, slit diaphragm problem, where you can have problems. And there's a very interesting phenomenon that happens in congenital nephrotic syndrome. So if you've got an NPHS1 or NPHS2, which is a nephrin or a podosin mutation, when you put in a kidney that actually has nephrin or podosin in there, just like sometimes when you put in a kidney, a normal kidney into somebody who's got Alport's, they can actually develop an antibody against the protein that they've never seen, and they can develop an FSGS type lesion due to a totally different de novo mechanism, and you can actually measure those antibodies, so that's very interesting. So in this particular case, I think the correct formulation is that his chances of recurrence are very low because he does not have an immune factor related FSGS, so it's not going to cause a problem for him. All right, so case number 2 is a 69.
Dr. Irfan, can I ask one question? I'm sorry.
Yes.
One quick question from Dr. Latif, actually. Histologically, we see biopsies like that in which you have like 4 out of 8 globally sclerosed gloms. Would this be called as a diagnostic thing as an advanced global glomerulosclerosis, or would Dr. Latif would call it like as if still FSGS? Sometimes our biopsies are labeled, and what's the cutoff to call it as advanced global? Because, you know, I mean, I agree with you all basically that it should be managed conservatively, but I mean, regarding the definition and histological diagnosis, conclusive one, what would you categorize it as?
Shanila, that's a pathology question. I'll let you feel that.
Okay, so normally all of us, when we age, like at the age of 40, normally we can have 10% globally sclerosed glomeruli. When you hit age 80, it becomes like 30% globally sclerosed glomeruli. So I have to look at the patient's age and the percentage of globally sclerosed glomeruli. If I see a 20-year-old girl with 30% globally sclerosed glomeruli, then it's not normal, right? Then I have to discuss why she's having a globally sclerosed glomeruli. Is there anything causing increased number of globally? We try not to make a diagnosis of FSGS until and unless I see a segmental sclerosed glomerulus on my biopsy, because it's a serious diagnosis, and without having, I mean, the comment is always there that due to the sample issues, due to the biopsy side, FSGS should be considered or cannot be ruled out or things like that. But just on the basis of globally sclerosed, I don't make that diagnosis. And plus, I have to see the percentage. As I said, if it's normal percentage, I don't even worry about it. And if the clinicians tell me, yeah, the significant like a nephrotic range proteinuria and excessive globally sclerosed glomeruli, then I rule out every other cause of proteinuria first, like minimal change. Usually minimal change, you don't see globally sclerosed, you see normal glomeruli. And in minimal change also don't give you any interstitial fibrosis. That's another thing I look for FSGS, if there is any interstitial fibrosis, because simply means it's chronic disease. And then membranous GN, any, like if old patient amyloid deposits, we have to rule out all other causes of proteinuria before I can say that this could be FSGS, cannot be diagnostic, like histologically confirmed, because there's no segmentally sclerosed glomeruli, but should be considered as FSGS because it's more than normal percentage of globally sclerosed glomeruli.
In this particular case, this is FSGS or advanced global sclerosis?
I didn't even pay attention to the case. This one, the first case or the second?
No, this is I put up the biopsy report, Shanila. So you see the light microscopy, 3 of the 8 have focal sclerotic lesions, 4 of the 8 have global sclerotic lesions, and 1 glom is normal.
Yeah, so it's FSGS. It's basically 90% total out of 8. You see 7 are involved, either global or segmental. When you say focal sclerotic means FSGS, like focal segmental glomerulosclerosis. So 90% are involved and it's advanced disease, only 1 is normal. And also has severe vascular disease, like severe arterial and arteriolar hyalinosis. It means severe vascular disease means hypertension, most likely. IF is negative, and significant food process effacement. So this is FSG due to hypertension.
So just to add to that, when you have FSGS that stands for a long period of time, remember that a misdirected filtration and the filtrate kind of coming down towards the tubule, eventually it will lead to global glomerulosclerosis. The entire glomerulus would get involved and die. So the key here is you find the tombstones there, you find the focally sclerotic lesions. So if you didn't find these 3 focally sclerotic lesions and only found the globally sclerotic lesions, then you might have a problem making a distinction between FSGS or what is known as FG, focal glomerulosclerotic disease. So,
thank you.
Okay, so let's just power ahead. We are actually already way behind. So I'm going to power ahead on the second case here. This is a case I blew. So just to let you know, so 69-year-old African-American female referred with proteinuria, known proteinuria for over a decade. Comorbidities were, she was a little on the heavier side, not too much though. Not by American standards anyways, hypertension and recent diagnosis of type 2 diabetes. She was diet controlled, hemoglobin A1C was about 6.8%. Her mother has a history of hypertension and actually has advanced chronic kidney disease, and her mom was awaiting initiation of renal replacement therapy. She must have been in the high 80s. And so on her 24-hour urine study, the proteinuria was 7 grams, creatinine was 1.4, serologies were negative, albumin was 4, cholesterol was a little high, but not terrible. She was reasonably controlled on atorvastatin, and a screen for paraproteins was negative. She was placed on a good dose of ARB and a kidney biopsy was performed. Shanila, this is the biopsy. You want to walk us through this? Shanila, you there?
Sorry, my mic was off. So this is a silver stain. You have 2 glomeruli. Left-hand side looks almost normal glomerulus. The right-hand side, you can see there is a segment right there that has podocyte proliferation there. The capillary loops does not look normal. They look like a little bit damaged or sclerotic or fibrosed. There's no red blood cells in the capillary loops. So that's a segment that has FSGS right there. So this is FSGS. And since it's, I tried to classify, but I couldn't put this in any classification. So I will call it NOS type. This is not fitting to any other classification. Yeah, so this is a trichrome.
Right.
So this is a trichrome. You can see the segment that's sclerosed. This is the on HNE. You also can see the middle portion of the glomerulus is sclerosed, and there is some hyaline material right there. So it's like a proteinaceous material there. And this is IgM staining. The problem with FSGS, the segment that's sclerosed can entrap some proteins. An IgM antibody is a bigger molecule, so it entraps in FSGS. When we see IgM staining in FSGS, basically we ignore it. We don't make a big deal out of it unless and until I see deposits on my EM. Then I have to have IgM, C3, kappa, and lambda to think about the diagnosis of IgM nephropathy. IgM nephropathy is, some people don't even believe that it really exists. But if you don't have good EM deposits, just don't be very careful to call IgM nephropathy with just the IgM staining on FSGS cases. That's a effacement of the foot processes. You can see red blood cells. The dark black color cell is a red blood cell right there. The basement membrane is on top of it. And then the foot processes are all effaced, means they are all look like they're joined together. They are not separated the way they should be.
Thank you, Shanila. So how would you guys treat this patient? Conservative therapy, steroid trial, steroids and cyclosporin, cyclophosphamide, rituximab, and just so that you get to know me a little bit better, in my slides, Actar gel is always the wrong answer. You would never use Actar gel, but some people use it. So would you use Actar gel? So what would you guys do? So this is a 69-year-old. She's got nephrotic range proteinuria. Albumin is good. She's had a long vintage of proteinuria. We've known about this proteinuria for almost a decade. Albumin is 4, so she doesn't really have the nephrotic syndrome, but she does have nephrotic range proteinuria. Creatinine is mildly abnormal, but she's 69 years old. We've seen the biopsy. Biopsy doesn't look too bad. You've got the foot process replacement. So what type of FSGS are we dealing with? Is this immune factor related FSGS? Is this adaptive FSGS? Is this genetic FSGS? What type are we looking at?
The available data, it doesn't seem to be immune mediated FSGS because there isn't any nephrotic syndrome florid. Albumin is normal and cholesterol is not that sky high that it usually is in terms of when the nephrotic syndrome is fully functional. So conservative therapy is the answer, and for me.
Very good. I that's exactly what we thought as well. Anybody, any other ideas before I tell you what the course of this patient was? Just to kind of tell you how we can sometimes get fooled. So that's exactly what I thought in this patient. And so we placed her on.
How long is the diabetes, history of diabetes on this patient?
It was recent. Hang on, let me go back. I forget, so let me take a look. But there's no diabetic nephropathy in the biopsy.
Okay, and how? So is the result controlled also?
Recent, yeah. I don't remember. It was within the past year or so that she was diagnosed. It wasn't too long. But with type 2 diabetes, you may have been a diabetic for a fair amount of time before somebody homed onto it. But for whatever it's worth, we didn't see any diabetic nephropathy in the biopsy.
Just two more questions about the case.
Yes.
One is the degree of proteinuria in the past. So was it like low in the past and high now? And the trend of the creatinine.
Very good. So, what we could gather was just UAs. We did not have a protein creatinine ratio before, and mostly it was in the 1+ to 2+ range. We had 2 snapshots in the past 5 or 7 years. So she did have proteinuria, but we don't have a quantitation. And her creatinine was in the 1.2, 1.3, 1.4 range over the past at least year.
And excuse me, Dr. Mokum here. What about Apollo genes curated?
We don't have that yet. No, we have not sent that.
I mean,
she was Caucasian, just to make a point.
African American, she was probably.
If I wrote African American, that is incorrect. She's Caucasian.
Oh, I've totally changed it.
Yeah, this is, I'm very sorry. Yeah, that is incorrect. She's Caucasian. Thank you for pointing that out, but yeah, she's Caucasian. But again, just to make a point, we don't see collapsing nephropathy here. I'm so used to writing African American that I probably typed that in. She's Caucasian. I know her well.
Yeah. That, I mean, right, there's a no typical nephrotic syndrome on this patient, but you know, that patient with 7 grams of proteinuria. I don't know how much effective that would be just ACE inhibitor or ARBs on this patient. This is a bad prognostic sign for this patient. Okay, so I know it's not nephrotic syndrome, but again, you have to think about whether any short course of steroids is helpful, or you have to give a try for that or not. I mean, there's some arguments against that, some arguments for that. I mean, against that, there's no nephrotic syndrome. But for that, when you try that, she has 7 grams of proteinuria. That's a bad prognostic sign. And you have to see whether she has I mean, there's no like a tip, pathology here, right? I mean,
now it was signed out as an NOS.
NOS, yes. So again,
actually, I'm sorry. I think this is Dr. Irfan. I think this scenario is very common in Pakistan. People with not typical nephrotic syndrome, but with significant nephrotic range proteinuria, newly diagnosed diabetics or non-diabetics, even their proteinuria going up to over 10 grams, but without any significant edema or dyslipidemias or hypoalbuminemia. And I think that's what sometimes we usually do commonly encounter quite often.
Yes, and that is this is a real life problem. We see this a lot, right? So I think what Dr. Abbas is saying is that he's worried a little bit that there's a lot of protein here. So what about that? I mean, would giving her immunosuppression on top of RAS blockade, would that help? What do you guys think of that?
Would that hurt for a little trial?
Yeah, that's a question. I mean, she's 69 years old. Do you want to give her some steroids? She's got some diabetes. What are we treating? That's the question, right? So what I thought when I was looking at this was that this is maybe some form of either an adaptive FSGS or a genetic FSGS. Her mother has got disease. She's had slowly progressing proteinuria over the past 10 years. And so I wasn't really enthusiastic that this is a immune factor or circulating permeability factor related FSGS. So in the interest of time, what I elected to do was to put her on an ACE inhibitor and see how she did. So she went home on an ACE inhibitor. I saw her in 2 months after that, and guess what she presented with? She had full-blown nephrotic syndrome at that time. So we had to put her on steroids at that time. So if we had listened to Dr. Abbas and put her on steroids at that time, maybe we would have avoided precipitation of nephrotic syndrome. But the point I'm trying to make is that sometimes all these things that we do are just guesstimates, and we have to make sure that we maintain a degree of humility and follow the patient closely to make sure that they're behaving the way we think they need to be behaving. Anyway, so we move on to the next case.
Just if I may, I know you're pressed for time.
Yes.
But I just want to know, what's the reason for not developing nephrotic syndrome for a florid nephrotic range proteinuria patient? I know this theory, but what's your understanding regarding it? And then I have a question.
Yes, so I think it is the degree of proteinuria that we are talking about and the rate of this development. So what happens in adaptive FSGS is that it's a very slow process. It happens over years. In FSGS, which is due to an immune factor, it happens within days. In FSGS, which is because of, for instance, parvo, it happens in days because that's a diffuse podocytopathy as well. So when you have a diffuse podocytopathy due to a circulating immune factor or an infectious agent, that progresses really, really fast. And the amount of proteinuria goes from 0 to 60 in 2.5 seconds. So that's a totally different animal than somebody who's had hypertension for 15 years and they've had a very slow progression of disease. So I think it's the rate of precipitation and degree of precipitation of proteinuria that makes the difference. I'm sorry, you had a question?
Okay. Yeah. So there was a related theory that if a patient is having a focal or adoptive FSGS, some of the nephrons are not handling the nephron that sodium that well, and the other nephrons are handling sodium better. And there is natriuresis in some nephron, and then some are handling it better. So the edema doesn't develop that much. So that theory kind of fades away when we think of TRPC6 or alpha-actinin 4, which develops slowly in the third and the fourth decade of life. It doesn't apply to it. So the theory that you just mentioned, I always had that in mind, but that other theory that doesn't fit in with this example. Because in TRPC6 and alpha-actinin 4, there is supposedly more than 80% of podocytopathy. So all the nephrons are involved, but still the patient does not develop that kind of florid nephrotic syndrome that we expect.
Right. But you're assuming that when you have a genetic malformation of any type, be that alpha-actinin 4, TRPC6, or yada yada, that the penetration and degree of podocyte dysfunction is absolute. That is not true. So having a genetic mutation and massive involvement of podocytes and having a circulating immune factor and having massive involvement of podocyte lead to different ranges of podocyte dysfunction. So when you've got a TRPC6 mutation and an alpha-actinin 4 or CD2AP, what you see is, in their second or third decade, they will have very little proteinuria, and then it takes years for that to go up. So it's a very slow process. On the other hand, when you have somebody who's got a circulating immune factor related disease, they may be normal a month ago and now they have massive nephrotic syndrome. So the range of precipitation is different. These are totally different disorders. All right.
Exactly. So thank you so much, because this is an extremely important learning from Pakistan point of view. We don't have EM. So I am really sorry that I had to ask it again. Just like stay with this question that somebody is having a trypsin-6 or alpha-actinin 4 deficiency or mutation, sorry, and he develops a slowly progressive proteinuria. How are we going to differentiate it from an adoptive FSGS without EM in Pakistan?
You probably won't be able to do that. But it really doesn't make a difference, because the thing that you have to decide is, unless there's a family history. So if there's a de novo mutation, then you can. If there's a family history, then that will point towards it. But what you have to really decide is this FSGS going to respond to immunosuppression? And that's the answer that you have to make. And so barring, like the case I mentioned, which fooled me, but it eventually disclosed itself. If this was an adaptive FSGS like I had thought, what I would see in the 2-month mark or 3-month mark is some degree of respite in the proteinuria, and then she would march towards progressive kidney disease, as would most of our hypertensive with secondary FSGS. But if this were, let's say, a CD2AP mutation or something, the same thing would happen. You probably won't be able to make a positive diagnosis without genetic testing being available. But the more important question to answer is this patient going to respond to immunosuppression or not? So even in the United States, we don't send genetic testing for everybody. We try to figure out which patients would really need them. Usually younger patients where we're thinking in terms of transplantation or something. So I think that the lesson to take from here is we have to kind of have a picture in our mind where we can identify and tease out which patients are going to be good candidates for immunosuppression and which candidates have non-permeability factor related FSGS, probably not going to respond to immunosuppression. Does that answer your question? Anybody else want to take a stab at that?
Very last thing in that, is it, I have gone through the literature and I found out that there is a partially responsive case reports in some of the genetic FSGS too. steroid responsive, partially responsive, not completely responsive. Is that so, or is it just I think misled case reports that are there in the literature?
I find it hard to kind of tease all of that out because these are just case reports. There's no, robust data on any of that. Most of these patients are placed on ACE inhibitors or ARBs at the time of diagnosis. It's kind of hard to say what's responding where. And even in a rare situation, that's a rare situation of a rare situation. So I like to focus on the 95% that we are dealing with. If you come across a really rare situation, then you focus on that and try to sort that out based on the merits of that case. So I think we're really behind on time, so I'd like to quickly finish the third case here. So this is a 48-year-old female, generally quite healthy. In summer of 2017, developed edema and noted her urine was foamy. She was referred to our GN clinic. Her albumin was 1.4. She had 11 grams of protein. Creatinine was 0.6. Biopsy showed 12 gloms, 2 were globally sclerotic. IFTA was less than 10%. She had segmental sclerosis with visceral cell hyperplasia in 1 glomerulus. The immunofluorescence was dark. EM showed diffuse foot process effacement. So this is the real deal. You're dealing with an immune factor-related FSGS here, circulating permeability factor. So I think everybody would agree that we need to treat this patient with immunosuppression. What is the prognosis of this disease? Would you anticoagulate this patient? While you guys think about that, I'm going to show you what happened. So she was started on high-dose steroids in October of 2017. She responded over the next 3 or 4 months and then eventually went into complete remission. She was on full-dose steroids, and the recommended regimen for this is 1 milligram per kilogram. Usually we put them on 60 milligrams. In bigger people, we can go up to 80 milligrams, or we can do 2 mg per kg on alternate days. And the important thing is this is not minimal change disease. This is FSGS. It takes a long time to respond. If this was minimal change disease and we had started treatment here, she would have responded by this time. This is kind of very, very par for the course. This is a very typical course for an FSGS patient. Just because we are way over time and I need to stop in the next 2 or 3 minutes. We did anticoagulate her because her albumin was very low. We do place them on fungal prophylaxis and PJP prophylaxis. The recommendation is if you're going to be on a maintenance dose of more than 30 milligrams a day, you probably need to put them on PJP prophylaxis. We don't routinely use GI prophylaxis. And the important thing is when to wean. We wean them once the proteinuria is stable. So in her particular case, we kept her on full dose steroids till I think about February. And at that point, we started weaning slowly afterwards. So this is, a cartoon of full-blown nephrotic syndrome treatment. I'm going to skip over that. We'll pick it up on the next talk. And I'm going to quickly switch over to Dr. Umar Farouk, who is going to talk to us about the human cost of this disease and share a very interesting case that he has been dealing with. And then we'll roll some of that over into the talk for next week as well. Umar, all yours, my friend. Would you mind? I'm going to stop sharing my screen if you could start sharing yours.
Please do that. So I think I have sent you a text privately in chat that the discussion for your cases have been, going fantastic, and everybody's asking wonderful questions, and I think there are good answers. So one option is, and I will open this for everybody, is like, because we got an extra week that I present my case next time, because I will have to do, I will take 15 minutes. I have 15 slides and I know that I'm going to take 15 minutes. The other is like, as we are in the flow, everybody has like, in the mood, and I can share, because mine is the patient's journey of FSGS from her words. I'm actually not the nephrologist presenting. Actually, I will ask the patient to present and I will use her words. So what's the consensus? Should I go and present or next week? And we can have more question answer on the cases we did before.
My vote is please go ahead. I don't know.
Okay, thank you. Okay, so maybe I should go.
Of the next week also we left it open, but again, majority of people, they want now, that's okay. And maybe they want to next week, we'll left it open for next week also for the same discussion, because I knew that this is not a small topic at all.
So I have only one affirmation or recommendation. Anybody else is interested, still awake? I will go. Otherwise,
It's kind of difficult at this time of the night. We have work early morning, so I think in the interest of our concentration, I think next week would be great.
Yeah, that's right.
So can I suggest something then? Can we go back to Dr. Agha's third case and finish that? Is that okay? Because we just heard the case, and if you want to present your points.
Yes. I'm going to share my slide again. Can you see can you see the slide which says Dr. Umar Farooq?
Yes, you can.
All right. So let me go back to the third case. I kind of rushed through that a little bit. So what are the questions on this?
What does PJP stand for?
Pneumocystis jirovecii pneumonia.
Okay.
When we were younger, we used to call it PCP, but that's what the ID people do. They keep changing names of these bugs all the time. So it's called PJP now. So
not making us easier. So my question is very, when do you anticoagulate these patients, and what the level of albumin you see? Serum albumin.
What do you want to take us that? I don't want to be yapping. So I didn't mean for it to be this way. We have to find a better way of, having more people chiming in. Otherwise, it turns into a lecture. So, Omar, I'll field it out to you. What's your practice, my friend?
So I think in my presentation, I had a question, and I would ask everybody to poll or say A, B, C, do you really anticoagulate in patients with nephrotic syndrome? What's your practice? And I think it's good to, because the practice has evolved in the last 10 to 12 years. I have been practicing in USA, and I know there is so much variability in utility and use of anticoagulation, even in the United States. So even if you present this question to all my other faculty, if there are 10 people in the room, you will have 5 different answers to it, because I don't think we have robust data, but we do have a good guidance or guidelines as how you handle this. To me, I will look at what kind of beast I'm dealing with. I think we discussed a lot before, like classic nephrotic patient with heavy proteinuria, etc. I will look at their albumin level, so less than 2 to 3, and more than 3. Then I will see what's the underlying diagnosis. So you put membranous in one category, and everything which is non-membranous into the category, into the other category. And then if the patient is pregnant or not. So assessment really would be, so this is, if this patient is not membranous and the albumin is less than 2, so what's the risk for bleeding? If the patient is not at increased risk of bleeding, this particular patient should be treated with anticoagulation. And the option I would choose either preferably, low molecular weight heparin at the treatment dose. So the intention is to prevent any thrombotic event, but really use the treatment dose and or Coumadin, the warfarin, because in this case, the proteinuria is already less than 2. If this was, patient with membranous, then I would have even use anticoagulation even when the serum albumin is higher than 2. So my answer is yes, I will use anticoagulation for this patient.
That was very thorough, and I totally agree with everything that Omar said. Any other views on that? Any dissent? Anybody would do it differently?
Yeah, again.
Right? Abbas, go ahead.
Yeah, definitely. I practice any patient who has nephrotic syndrome and albumin less than 2. Highly likely that we do anticoagulation, and particularly with membranous or minimal change disease also. And also the choice of anticoagulant, low molecular weight heparin is one choice, very good choice. And also with the oral anticoagulants, we use that too, like Eliquis or Xarelto.
So, this is a little bit of a data-free zone. And so I think this is mostly opinion-based, like Umar mentioned. So I'll just make one or two other points in anticoagulation in these disorders, and that is, like Umar mentioned, membranous and non-membranous are totally different animals. In membranous, your risk of thrombosis is the highest at the time of diagnosis. So in the first few months, so if you've got somebody with membranous, you need to run and anticoagulate them, especially if their albumin is 2.5, 2, certainly below 2, you need to anticoagulate them. In cases of FSGS and other type of disorders that lead to nephrotic syndrome, the risk is higher a little farther down the line. And it just is because membranous does other things. And when we talk about membranous, we'll talk about the coagulation issues that come up with that. But certainly if you've got membranous, it's a no-brainer, you need to do that. With FSGS, with severe disease, when your albumin is below 2, I would certainly do that. Sometimes I've run and I've gotten lucky when it's minimal change disease. I know I'm gonna get a response in a couple of weeks. If they look okay, I put them on steroids and then reassess them in a few weeks. And if the proteinuria has gone away, I might not anticoagulate them. But if the proteinuria is still there, then I would. So it's a style thing. It's a little bit of gestalt, but there's very little good data out there. Most of these are case series. Now, NOACs are very attractive. There are case reports of successful use of NOACs in membranous, even in membranous, along with other GNs. And I actually have started using NOACs in my few patients that I've put them on NOACs. They've been able to tolerate them well, and we've not had any problems. And that doesn't mean that they're successful. It just means that I've not seen an event. So it takes years if you're doing your own data. It takes years to develop a trend, but it looks like they work based on whatever literature we have. They seem to work. Umar, what are your what are your views about NOACs in membranous? I mean, I think NOACs in FSGS are probably an easier answer, but what about membranous?
So again, I think this is data-free zone. So the patients, I think, who have some contraindications to heparin, or there are issues with warfarin, I think the NOACs now are just getting more popular, and I can see that the utility of these drugs will continue to increase, and this is now being recommended. The other 2 points is, one is the duration of anticoagulation, and the role of baby aspirin. So does baby aspirin still have, it's cheap, it's available. So the duration of anticoagulation is really, I think, again, opinion-based. I don't think we have very strong data. Is the duration of nephrotic syndrome, and or you can track it. You can follow the albumin level, whether you want to go above 2 or up close to 3. It's up to you. But really, and I think minimal change and rapidly responsive FSGS, if we find one, those are the conditions when you can just wait for the steroids to kick in. I think you probably don't need it. But other conditions, I think the duration of nephrosis is would be my answer. The second thing is the aspirin. So I mean, when I was looking the answer to it, again, people who don't fall into very advanced risk categories, I think that if the albumin urea is the albumin in the serum is still more than 3 or between 2 and 3 for some other cases, and pregnancy when the albumin urea is serum albumin is on the high side, people have used just aspirin. Again, there are it's opinion based and practice based. So I think really I want to ask everybody, especially in Pakistan, the question: do you use anticoagulation? What do you use? How aggressive do you think we should be to use anticoagulation? Because the downsides are always there. There are issues with bleeding and all that, but there are a number needed to treat concept. Like if you prevent one bad DVT or one bad thrombotic event, I think as we just heard, surgeons in USA, they are really afraid of thrombotic problem rather than bleeding problem, right? So I remember transplant surgeons saying they don't care about bleeding because blood transfusion is easily available, But if the allograft or is thrombosed or there is big DVT somewhere else or PE. So I'm just kind of, bringing this question back to my colleagues in Pakistan is, what is your experience and what should be done? I think in your practice, I think because this really should be back to you, and then maybe you can guide us as maybe we can change our practice here.
Well, if I may respond to that, I think it's very humble of you want to change practices by listening to what we have to do in Pakistan. But the real story is mostly what in my department, what we have as a policy is if the albumin is less than 2, we do anticoagulate. But if it's above 2, generally aspirin is found to be good. The baby aspirin that you were just talking about. And in membranous, yes, in membranous, we have a low threshold for starting anticoagulation, and that's about it. And previously, the problem here, you just mentioned that it's a data-free zone, and what to ask about the data back home. We have just started collecting all the data of the glomerulonephritis in our department, and we are running 2 studies. So probably in a couple of years, we'll be coming up with our own data, and let's see how the.
Thank you.
Okay. So this is Ahad. If I may just contribute just a couple of points. So it's not directly related to anticoagulation, but I'll come to that point as well, because I just want to brief you guys what I see happening in Pakistan. So as opposed to the first 2 things, so essentially the talk was all about to find out if the FSGS that we have diagnosed, whether it is responsive to the immunosuppression, yes or no. Number 2 is that whether it will recur after transplantation. So essentially what I do say, so let me just play the devil's advocate, and for the sake of my ego, let's just say that this is not my practice. But what I do see is that you see any patient coming in with FSGS, and every patient gets a trial of steroids for 3 weeks, regardless of the valid points made by Dr. Agha saying that whether it is nephrotic, non-nephrotic, whether it's the presence of hypertension or no hypertension, whether there is diffuse sclerosis, effacement, or not. But every patient, essentially what we see is that, whether it is a medic who is treating the nephrology patients, is that they get, 3 weeks of steroids. And if the patient responds, they sort of say that this is the primary FSGS and it will probably recur. I mean, you guys can definitely comment on that. I guess that is not scientific evidence. That is more of like a chemo treatment probably, but that is what happens here. Number 3 is that essentially, I don't think NOACs are being used very confidently here. I am definitely not confident enough to use NOACs up till now. So essentially more patients are being put on warfarin, and essentially it is being sort of, when the albumin is less than 2, and if the patient membranous, that is when the patient is being put on warfarin, and we monitor the INR. At least that's my experience.
Can I comment on this very quick? I think I suggest that this practice needs to be stopped at giving everybody steroids. I mean, it's not very difficult to differentiate even without biopsy on clinical history, and also with biopsy, it's easy to find out that which patient needs steroid and which patient not. If there's a doubtful, then you can say, but if some patients that clearly do not need steroids, so those patients should not be given steroids. I mean, similarly, that's why I proposed that in my post like a couple of weeks ago, that we have so many top-notch nephrologists at this forum, and we should start some kind of research or study something to guide what can be done in that Pakistan situation, what is availability there. So
I think this is a very important point that Ahad brought up, because one point is very important for you people to know in US is that the patients that we are seeing in Lahore, we might not be the primary physicians, making that decision. The patients already probably have had steroids before, number 1. Number 2 is that we don't know as to what has the extent of the treatment been for the most part, because patients may not be literate enough to tell us. And the most important thing that might be the differentiating point, the onset of proteinuria and the symptoms and how they were started on the treatment. I mean, that's really, really important for us to know. And that is not, so my point was that most of the patients, what I see with FSGS is with some renal dysfunction and subnephrotic proteinuria. I don't know if it is an adaptive one or if it's a primary burned out one, which has probably become an adaptive one. I'm not sure exactly. So, I mean, all these cases are in the middle, in the gray zone. So you are stuck. They might still have some nephrotic range proteinuria. They may not have full-blown nephrotic syndrome. And you're in the middle of things and you're trying to decide, you don't have any labs. It happened 1 year ago, 6 months ago, partially treated. I don't know what it was, complete or partial remission. We don't have any data or anything like that. That becomes a very difficult ball game for us to tackle at that point when we are seeing patients in 15, 20 minutes and we have to make a decision in this regard.
Yeah, the only thing I would suggest is that, that's a tough situation that's kind of akin to the second case where, the patient declared themselves to be nephrotic, after we had made the determination the other way. I think sometimes the first thing is if you were worried about this being an immune factor related or permeability factor related FSGS and they're subnephrotic, even if it is that disease, if it's proven that this is what it is, that's really not an indication to immunosuppress them because they're subnephrotic. You just put them on an ACE inhibitor and follow them and see which way that worm is going to turn. And if you have issues about a patient where you're not sure and they're not nephrotic and their albumin is good, they just have proteinuria, then there is no rush. It's a slow burn disease. It's not proliferative lupus where if you don't treat them for 4 weeks, they're gonna kill the kidney. This is a slow burn disease. This is a disease that takes some time. You can follow them up at 2 weeks, at 4 weeks, at 6 weeks. And nishana sahi karke to phir fire karna chahiye, warna gabad ho jaye.
And
so
if I may add,
I think the 3 weeks, if you give steroids, if you give somebody 3 weeks of steroids and then stop, I think this is actually another disservice to them because this is a stubborn disease. Even minimal change, when it responds, you continue for several weeks, like
3 months,
12, 14, and you may not see a response in 3 weeks if this was meant to show you some response. I'll stop here, and I know Dr. Linwala wants to say something.
Let me say quick one. I mean, this is not FSGS. I mean, I'm honest. Even very minority of the patients with FSGS, they respond to steroids. Minority patients, not the majority of the patients. So steroid is not must treatment for them. It's not like you can give like minimum change. You give steroid for a few months or a few weeks, and you see the response. So FSGS is totally different.
I agree with you. All careful observation, following these patients closely. But let me tell you something. In Pakistan, when I moved back over here, I mean, I saw quite a few patients. Basically, I mean, what to talk of FSGS? The thing in the other cities, other than the main cities, people are not willing for biopsies, and they are put on prednisolone, basically only for proteinuria without a diagnosis. I mean, these are, more graver, and that is an extremely, I mean, it's not that unusual. It's not rare. I mean, it's pretty common. You would refuse a biopsy, you would put them on steroids, and you would treat the proteinuria. That's common practice.
That's the point that I wanted to make, that usually renal biopsy is not covered by insurance because none of us, all the doctors that are talking from Pakistan, I think hardly any one of them is covered in insurance. So what to talk of the patient or somebody who is coming from Gujranwala, Spurbs, or some village,
even remote areas.
So the thing is, all of them, they have some kind of myth in their family that the renal biopsy is probably going to kill you and they are not going to do the biopsy. And then once we go for the treatment, if we start warfarin to somebody who has just visited us and next time we aren't sure that when he is going to visit us, we are reluctant of starting warfarin and heparin and anticoagulation and all that.
Exactly.
And so next time, what I feel like is if you see a prescription where without renal biopsy, somebody has given steroid to a nephrotic patient, that doctor may not be an idiot. He must be somebody who is just jammed in the system downstairs in Pakistan. I just wanted to ask one thing, and I want to be clear in that. There was a trial, FSGS clinical trial, NIH funded trial. They included patients on steroid who have taken 4 weeks of steroids. So probably that was a bad inclusion criteria. But knowing that, it just occurred to me, probably it's not like if only in Pakistan, people are giving 4 to 8 week steroids and then labeling patients steroid resistant. So one thing is, on one hand, I totally agree to Dr. Umar that 3 or 4 weeks is totally insufficient. But on the other hand, I have seen that a few of times I've stopped patients after 8 weeks of steroids and they did not respond. And then they went to somebody else and he or she was told that you should have been given 16 weeks of steroids, not 10 or 12 weeks. So it doesn't happen like that. The proteinuria falls off the cliff at 16 weeks. There should be some improvement in proteinuria from 8 weeks onward for it to be continued to 16 weeks. Is that so, or is it not?
Yeah, so that's actually an interesting insight. So the definition of steroid resistance is lack of response at 16 weeks. So FSGS, when you look at people who actually responded eventually, you can actually draw a line through 16 weeks. People who got 16 weeks of 1 mg per kg are more likely to have gotten a response than those people who had a shorter exposure to steroids. So that's where the 16 weeks comes from. But you're right, this is usually the response pattern in FSGS. Now, this is typical. This is not everybody. Essentially, what you see is the proteinuria starts coming down, but if you stop here or stop here or stop here, it'll go back up. Even minimal change disease, where you drop it like this, right? So if you have minimal change disease and you've had a response, you started in October, by November, there's no protein in the urine, you've had 4 or 6 weeks of steroid, and then you stop, there's an upward of 50% chance that the guy would relapse.
Yes, so if I may add,
yes.
Right in this graph, I'm sorry I'm interrupting you. If this graph was at 10 gram for the next 8 weeks,
right,
then what would you have done?
I would have continued for 16 weeks because sometimes it takes a longer period of time. So it goes like this, and then it starts coming down. And so there's people who actually require longer exposure to steroids. It's not a uniform disease. It depends on when you're catching them. So if you catch them early and if you've got them at the tip variant stage, you may see a response like this. If you've got NOS developed, you probably are going to see a response like this. And if you're mistreating them, if you've got genetic FSGS and you thought that this is immune factor related FSGS, you won't see anything. And so this is where you kind of start figuring out, okay, this is not going to respond. And then you're going to send for genetic testing if you're in the United States, or declare them steroid resistant if you're in Pakistan. But you have to give them full treatment. You cannot stop before the 16 weeks, thinking that I have, because that's kind of where the data tells you that an exposure to 16 weeks maximizes your chances of a response. But we're all clinicians. So if you see that you got somebody who's got 10, 11 grams based on this, and this is their protein ratio, and this is what they're doing, and now it's October, November, December, January, or December, and there's absolutely no response, and they're having side effects with steroids, I would take them off. I would think of something else. Over here,
that's what I'm talking about. But usually, that brings me to another point, and I want my Pakistani colleagues to comment. Is it just my feeling, or is it true that 16 weeks of steroids at 1 mg per kg, our patients just simply don't tolerate that 16 weeks of steroids? They are Cushingoid. For example, I can tell you a number of stories where I have treated patient. The patient have responded at 12 weeks period and 16 weeks period of 1 mg per kg. The proteinuria is gone. And when they walk into my clinic, somebody else is holding that patient and he's finding it hard to sit and stand from the seat of the patient. And I'm telling them, congratulations, your proteinuria is nil and you're healed. And he looks in the eyes of his mother and tells that I'm unable to sit up from a sitting posture, stand up from a sitting posture.
So
and you're telling me I'm fine.
I know you guys have your own, issues. Cannot do biopsy on every patient, but most of you are in referral center. You are a bigger center. that's the advantage of doing biopsy. So some patient I do biopsy, I know that patient is very diabetic badly, and it will be very hard to give steroids to that patient. I started cyclosporine from the beginning. I don't even put them on steroids. So if you have biopsy, you know this patient is not going to tolerate steroids, then you have other options also. I mean, you don't have to wait 16 weeks in that case, as you're right. You can save the kidney, but kill the patient. Right?
So if I may ask Dr. Ahad, Dr. Arslan, and Dr. Naman, what's their observation regarding the tolerability of steroids?
I agree with Aurangzeb. I agree with Aurangzeb wholeheartedly, because I mean the problem in Pakistan is that the patient is going to hate you basically, and Dr. Irfan, it's not a matter of, I mean, it's a matter of the choice. I mean, they're going to move to the next nephrologist, and you're going to lose up a patient whom you're trying to establish an appropriate standard of care. And I mean, one is side effects. I agree with him. Basically, they're gonna have bad proximal myopathy, and then you're gonna, I mean, they're gonna have a lot of issues with that. I mean, if they're diabetic, it's out a whole totally different ball game. But I mean, the other thing would be, I mean, they would be waiting for 1 to 2 months. Proteinuria is not subsiding. Their edema is not any better. Or maybe with some diuretics, you can just throw in and basically get them better. But the main thing would be they would move on. My thing would be if Aurangzeb is trying to ask that, you know, in that period of time, if you're not responding in this current clinical scenario, living in Pakistan, practicing in Lahore or Karachi or wherever you are, can you just, you know, just maybe switch on early to like CNI or something else and just, you know, get them off the, you know, the burden of steroids?
But actually,
so I think this is the concept for the first line agent, and I think, yeah, the alternative first line agent. I think I spoke about this. So we need to have a, you need to see what's in your back pocket. You have first line, you have alternative first line, maybe another backup, and then I think so one size does not fit all. I think if I mean, I understand like steroids are the standard first line agent, you know, but now patients are so some patients are educated. They will throw like a curveball at you as well. They will ask you, okay, what about vitamin R, vitamin rituximab? I have seen a lot of, you know, advertisement for rituximab. Can I just go to rituximab now? And then, so, you know, that's the other extreme of the problem. Sometimes we need to deal with it. Hey, I said like, no, stop. This is like a lifelong problem. Maybe, you know, you want to wait and give some easy things a chance. And I think this is where the role for alternative first line, because it really comes in because of the side effect profile from the steroids. So I think this is where, you know, we can, that's where I think I want to have a discussion within the group is like, what are the real problems on ground, and where you can make some adjustments earlier on. So you can, you know, patient is happy and also getting a good outcome.
Patients in Pakistan who do not like steroids, period. I mean to say, they don't want to be.
Nobody likes steroids. Nobody likes.
I know, but over here it's a very difficult situation. I tell you. I mean, no, I mean, you know, in US, I mean, I've been in US. I mean, it's not as a big a problem. I mean, trust me, females, young females, middle-aged females, I mean, they're ballooned up, you know, and I mean, it's a difficult problem. So going to CNI or CellSep, I mean, that's, I was hoping that we're going to discuss that next, as what are the other alternate options and when to pitch in those drugs.
One of the things that
let me add one thing, sir, over here. We are going for rituximab as a study in treatment-naive patients, and we are also giving steroids just as a starter. Now, the thing is, the satisfaction level also counts. If the patient isn't satisfied, I don't think the degree of Cushingoid features that the patient develops over here is similar to the patients that is Caucasian or Afro-American. I'm not sure. But Dr. Arslan, who has practiced over there, and he is now practicing over here, probably Dr. Noman also, they can comment better on it. For me, I think in Pakistan or subcontinent, I may say, steroid-sparing therapies are more successful in terms of patient compliance, satisfaction. I am not saying that in response, but certainly in terms of patient satisfaction and compliance.
No, that's a perfectly reasonable point. So this is what we are discussing. So we have actually started discussing the immune factor related FSGS for the first time. We have discussed one induction regimen. Next week, we are going to discuss alternate induction regimens. What are the other options that we have? And then how do you deal with steroid sensitive FSGS that relapses or becomes steroid dependent? and how do you deal with steroid-resistant FSGS. So that's all that we are going to talk about next time. But your points are well taken. The realities of life everywhere are that nobody wants to be on high-dose steroids open-endedly. And people over here get side effects just the same as they get, side effects in Pakistan. And all of those practical points are very well taken. And so you have to practice in the milieu in which you're practicing. And so we can sometimes get away with putting them on steroids for a longer period of time.
I may add just one thing, Dr. Irfan. The problem in Pakistan is that the patient is not bound to you. I mean, honestly, that is a very serious problem for the physician, nephrologist who's trying to help the patient. And in US, he's going to be bound to you. He's not going to go to any other place. He's going to trust you.
Actually, not true. That's actually not true.
No, it is.
Plenty of nephrologists. They can walk across the street and he's out.
They shop around.
Oh, trust me, and not as much as in Pakistan. I mean, they would go to every 6 nephrologists before they would come to one regimen. That doesn't happen in US. Trust me.
Dr. Arslan has been brutally honest today.
No, Dr. Arslan, just let me add one thing. In our society, every quack and hakim, they are giving steroids to the patients. And when we give them steroids, people say, what are you doing? Only they give 1 or 2 tablets and you are taking 9 or 6 tablets from this doctor, it will kill you. Even the medical store is telling the people like this. So we are in a very much difficulty to start steroids in our patients. That's very right.
Okay, Umar, I have a question. I know we're going to talk about this next week, but I'm just so curious that I can wait next week. So you saying that rituximab for FSGS, or that's you said that?
No, so patient asked me a question, and I think I will present that patient as well. Like, should I get rituximab now? And then I actually did not accept that idea from the patient in that patient's current situation. So we can have a discussion. I think please keep that for next time. But rituximab is not, so in the armamentarium for FSGS, as of now, the rituximab is a little bit behind as compared to membranous and vasculitis, literature. But eventually, you will find a lot of case reports and maybe few case series when it is effective. Did I answer your question, Avas?
Oh, yes, absolutely.
Thanks. So this is 3:05 p.m. Here, and I'm sure it's 11 or what time is it? 11 or 12? It's midnight. So I think we need to. So we are moved to the next day. Yes, this is important, but not like so please, my humble request is like if we adjourn the session today, if I have a second, somebody can vote, and then we can go to. We can wait for the next week.
Let's plan for the next, so we can have even more like a constructive. Everybody gone or still here? No.
Is there any suggestion about changing the time to maybe half an hour early or something, because it's almost midnight every Sunday that we have to go to bed?
Yeah, I mean the weather is changing and the time zone will also change. So I think we can start early.
I mean, if everybody agrees, I mean, it has to be a comfort level for everybody.
My question is, I mean, plan is for next week. Can we put a question ahead of time? Irfan, is that better for you? That so you can plan which, like if I have a case, I can send you my case, and then you can plan that which case need to be discussed.
I have a couple of cases that Dr. Aurangzeb has sent, so we will be talking about that. There was another case that I think Dr. Muzammal had sent, but that's an IgA case, so we will use that for our discussion when we discuss IgA. But yeah, if you have any cases that you need discussed, just send them to us, and I'll, you want to send them.
It's a quick answer, not like a detailed answer, just like quick. What you think.
Anything you want to, this is supposed to be an interactive thing. I don't want it to turn into a lecture. But at times you have to kind of give some basics to kind of frame the discussion. But after that, what's really beneficial is the discussion that we were having. How do you actually deal with these problems on ground? Because our way of dealing with them is very different in the United States than what your realities are on the ground over there. So you have to. I
would just request one thing by all of you. Actually, it would really be helpful for you at the end. I know what you practice in the US and all that. But if something has to be translated, like for us, for you to facilitate all of us over here that, I think like Dr. Obay said, just don't do steroid. Dr. Irfan said, we should stop waiting for 4 weeks. I mean, that really guides us a lot, basically, because sometimes, you're doing it so much that you really don't think out of the box. So I would, at the end, just please, if you have the opportunity to just say, okay, I think you should do it this way. That would really be helpful for us, because just saying it, we do it that way, may not be as much useful for all the folks over here.
I agree. Yes.
All right. I think we should call it an afternoon and a night and morning somewhere. So we'll see you next week then.
I agree. Thank you. Thank you, everyone. Thank you for joining. I think this is wonderful.
Thank you. Assalamu alaikum. Thank you very much.
Wa alaikum assalam.
Thanks a lot.